Hello, hello, everyone. How is everyone doing this beautiful Wednesday? Excited. It's
It's
like almost
actually like
Christmas, which is crazy.
it was so cold last week in Houston for us, and now it's a little bit warmer, so I feel happy today. How about y'all? Marisa, where are you based out of?
So I actually
North
moved from California to Florida last year, and so I'm in northern Florida. It actually got down to 35.
Oh, I was gonna say, well, you're warm. No, you're not. Oh my goodness.
Marisa, this
Well,
whole time I thought you were Team California West Coast, and I was like, we're gonna team up against Liz, and now I'm like, oh, just kidding.
Uh,
Chris.
my whole
Hi.
focus is still in California. I'm in Florida now.
Makes sense.
Yeah,
Makes
nice,
sense.
nice, nice. Okay, well, so excited to have you. I am so excited for today's talk. I feel like I personally have 5 million questions, so I know our audience will too. But let's kind of hop in and get started. Thank you all so much for joining. Today, we are joined by a special guest that we are really excited about, but of course, we want to cover a couple housekeeping items. Please remember these talks are educational. They're not intended to replace therapy. And of course, if you're feeling unsafe or suicidal, IOCDF is not a crisis hotline, and instead you should call 911, go to your local ER, or call 988. The goal of today and the goal of all of our live streams is that we bring new content, new education, and hopefully some aha moments or some exciting things that you can start to implement and practice and talk to your clinicians at home about. So I'm so excited. It's so good to see y'all. I can't believe we're like a day or two away from December, so that's wild. But we are joined by a special guest today, Marisa Mazza. Marisa is an incredible OCD clinician who Chris will talk and brag on your talk that happened at the online conference and the engagement and everything that happened. But really today, you guys, we're going to talk about acceptance and commitment therapy. We're going to talk a lot about ACT and ERP and how it's used for OCD, what it looks like, and ask probably a million questions, and we'll try our best to get to them. But of course, throughout today, if you guys have comments and questions, please put them in the comment box on the right-hand pane this way on your screen so that we can try our best to get to them and moderate them. But we're just so excited. Chris, I'm going to let you do an intro of both Marisa and goals for today, but I'm really excited, and I know I have my own list of questions. So thank you for joining us.
Well, my outstanding opening for her was when she was based in California. So now that she's in Florida, I have to rewrite. No, just kidding. As many of you know, one of the things that I love about the IOCDF is we have an online OCD conference, because as we see, we have people from all different states, all different countries that watch these lives and are participating. And in October, we had the online OCD conference. I don't know, Brennan might be able to put in the chat if you can still watch the presentations, but what I like is I watch them and put them on my TV and everything. But one of the talks after that got such resounding praise was Marisa, and I'll let her go into the details of her talk. But I think what was really cool about it is I'm a learner when I see something and it's visual and it's interactive and it's engaging. And she did a talk really about ACT and ERP in action. She did it with a person with OCD and talked about it. And I learned so much. And I think a lot of people in this community, because I get emails and people coming, are always asking about acceptance and commitment therapy. I think when a lot of people hear about it, they find it just makes like treatment click. Additionally, Marisa's also written a book with Lisa Coyne, an ACT workbook that I have clients that use and everything. But let's start with that, Marisa. Tell us a little bit about the idea of the presentation and sort of the people that missed it, a little bit what went on in that presentation, what you hope people get about ACT and ERP.
For sure. And thank you so much for having me here. I'm excited to be here and talk about ACT. So the presentation was sort of birthed out of kind of a couple of things. One is a lot of what I do with clients in therapy, a part of ACT is connecting folks to their values. So connecting them to what gives them purpose in life, what gives them meaning in life. And so it's not uncommon throughout the course of treatment for folks to be like, well, I really want to be doing more volunteer work here, or I really want to be, working in a place that does this. Like, I want to be more connected in these ways. And it's not uncommon for some of my clients to be like, I've gotten so much out of this treatment. I want to give back to the OCD community. And so the particular individual who allowed me to record our session was one of those people that was like, I want to give back. Like, I suffered for so long. And it wasn't until, me learning about OCD, connecting with evidence-based care, did it really improve. And so This individual was quite brave and allowed me to record the session. And one of the reasons why we talked about recording the sessions was to be able to train and educate other therapists on how to implement ACT and ERP. By no means did I do it the right way per se. I think there's many ways of practicing acceptance and using ERP as a way to practice acceptance. But like what you said earlier, when I think back to some of the most valuable training experiences I've had, it's seeing other people actually do it. Right. And so I wanted to be able to give that training opportunity, not only to the therapists within Choice Therapy, my practice, but also to the other therapists that I consult with.
Yeah. One of the things that, I always think about with treatment is in the beginning, when I was trained prior to ACT being as infused as it was sort of like you do the treatment and then the person can get back to life. And just like you were saying, I think of treatment as volunteer work, even if it has nothing to do with the client's triggers. Everybody has a choice each day with OCD. Like, am I going to sit there and give OCD a platform? Am I going to listen to it? Am I going to engage with it? Am I going to spend most of my day with this disorder? Or am I going to sort of say, hey, I hear you, but I really like volunteering for Meals on Wheels, and I like delivering food to veterans and to older people and to engage with them. And it's hard for me to do both, so I'm going to lean towards that. So can you talk about, I always get nervous when clients come to where I work for a higher level of care, and I ask them, has your therapist ever talked to you? What do you do all day? And they're like, oh, I sit at home and kind of just like compulse. And I'm like, well, has your therapist talked to you about even walking around the block or maybe getting a pet, et cetera? Why do you think engaging a client's values is actually helpful for recovery besides just like a distraction or just sort of a thing to do?
Yeah, because doing exposures is really hard. And so why bother doing something that's really hard unless it's meaningful to you? Right? Like, I hate going to the gym. I am one of those people that doesn't like it. Right. But I literally force myself to go to the gym, not to go to the gym, not to exercise. I do it because I want to be able to have adventures with my son as long as possible. I love hiking. I want to be able to do those things. Right. And so that helps motivate me to be able to then do those things. Right. And so connecting folks to what's in their heart, to what gives them that sense of purpose, I think helps with motivation. It helps to do the harder exposure, helps to get out of bed and take that walk, even when they don't want to.
I love it. And it's interesting. So we actually are hosting a little breakfast for OCD clinicians in the Houston area here tomorrow. And we're going to do like a case conceptualization for an hour. And I was like, we have to do values-based ERP. And we've all been talking about values-based ERP for a long time, but I feel like it hasn't really been disseminated to the broader clinician community. And I think that I just keep hearing people say things like ERP is cruel, ERP is harsh, and I'm like, well, but that means like you're not really doing ERP the way ERP was intended. Because at the end of the day, as you're saying, Marisa, like, if you're doing hard things, but it doesn't equate to something that's meaningful or important to you, why would you do it? And that's for anything in life, right? Like, most rewards come from a hard thing, like something hard we did or something hard we went through. But like, if there's not a good outcome, we're really like, I wouldn't want to do that. I don't like to do hard things just to do hard things. Like, that doesn't sound enjoyable to me, at least, maybe for some people. But I love this conversation because I think it's one that the community needs to hear so much about, is that really every treatment that you do for any disorder, right? But when we're talking about OCD specifically, it should be bringing you closer to your values, and it should be allowing you to live that life you want to be living, right? And with that, I have some other thoughts that we'll talk about later, of like when I feel like sometimes we use like, oh, that's not aligned with my values, as an excuse to like not do things we know we do need to do and that are aligned with our values. So we'll get to that later. But can you share a little bit more about just kind of like, I don't know if this is the right word, y'all correct me if I'm wrong, but I feel like it's like a difference. Utilizing ACT with ERP and having that be a part of your toolkit is, to me, a difference of like warm, empathetic ERP versus like rigid, face your fears sort of mentality. I don't know what your thoughts are, but.
Yeah. So I want to comment on something you said earlier. Like, even exposures can be done in a kind and compassionate way, right?
Every exposure should be done.
Yeah. And so one of the things I like to do is I like to hit folks hard with ACT in the beginning of treatment. And just to kind of back up for a second, ACT stands for acceptance and commitment therapy, and it's said as one word, ACT. And a big part of, or one of the processes that is focused on in ACT is values, right? And one of the beautiful things about sitting there and really digging into a person's values, defining their values, coming up with behaviors in line with their values, it helps with rapport. It like helps you connect with what's in their heart. I say there are a few gifts that our clients give us in therapy. And this goes back to like therapy 101, but I think sometimes we forget about this in like a mechanistic type of model, right? Which is their values, their emotions, their underlying fears, like all of these things are very vulnerable gifts our clients give us. And being able to identify them and use them within the models of treatment that we've known have been helpful for people can just make the work so much more meaningful and connected. I feel like it helps connect you and the client.
Yeah, Norvin asked at 910, what is ACT? And so thanks for giving a brief definition. I also think about it as like ACT is not just a treatment for OCD. I mean, I've heard of ACT for other things, but it's really been, utilized for individuals with OCD because it is so effective. And I think, one thing that a lot of people get tripped up is on that word acceptance. So maybe Marisa, if you could describe, because I think when people first hear that word acceptance, they're like, oh, well, I have thoughts about hitting people with my car. So you're saying I need to accept that I hit people with my car and I like it. And so can you talk a little bit more? So in acceptance, A in ACT, what specifically does acceptance look like? If I'm having intrusive thoughts, for instance, about hitting people with my car, so I choose to stop driving. I don't even want to go in an Uber because I think I might distract the Uber driver and cause him to or her to hit somebody, right? Like what does that concept of acceptance look like for somebody who gets intrusive, unwanted thoughts about maybe hitting people with their car?
Yeah. So a really quick definition of ACT would be, a willingness to experience what is. And what's for someone with OCD, it would be what is the obsession, the uncertainty, the feelings that go along with being in uncertainty, right? So a willingness to be able to be with those experiences while committing to what matters to you, right? So while committing to those values. So acceptance, I like to think of it as like a stance. It's like an open arms, like, okay, I don't like you, obsession. I don't like you feeling, but I'm willing to have you anyway in the service of moving closer to those things that matter to me in life, right? So, in the example that you're giving, it wouldn't necessarily mean accepting unwanted behaviors or behaviors that aren't in line with your values, right? But it would be, am I willing to be with this idea of like, I may one day hit someone in my car? If it also means I'm willing to continue to live my life and take that risk in the service of what? What about driving is important to you?
I think about it for me with traveling. I have a lot of like intrusive thoughts around traveling. And I just went to speak at a conference in London. And it was like, for me, how I like to think of ACT as well is like the commitment part for me is like what has helped me get over OCD. It's been like, I am done. Like most people watching this live, we've all with OCD, Liz, everybody else watching, we've all dedicated so much time to preventing ourselves from our happiness, from our growth and our strength when we really listen to OCD. So for me, I feel like at the end of treatment, I made a commitment to myself, to my family, like I am no longer making decisions based out of OCD. But I knew I was going to have thoughts and uncomfort, feelings, etc., about traveling. It was my first overseas trip. And the way that I like to think about acceptance is like what you just said is like, it is. I will have thoughts, they will be present. I will have feelings that will be present. I can choose to let those in like direct me to canceling this trip, or I can use them to direct me to go on the trip. So I think that's really, really powerful for everybody to hear is like the goal of treatment is not to like, I need to get rid of these thoughts and feelings and then I can experience life. It's like you can experience life despite having the thoughts and feelings, but people get scared of that acceptance word. So thank you for clarifying for sure.
Absolutely. Absolutely.
Yeah, I think it's so important that we are really clear that we're never asking patients to accept their worst case fears as truth. Instead, we're actually asking, as a part of OCD treatment, is that we ask you to accept probability, right? That everybody else accepts every day of their life. Like, we're not asking you to sit there and be like, okay, I'm going to accept that I might be a pedophile if you have pedophilia OCD. Like, of course not. Who would do that treatment? Like, don't sign me up. I'm not interested, right? But if it's like, okay, I need to accept the presence of that thought being there and choosing not to respond to it and letting it go. And that's how I work through it. That's really, really important. So I want to talk a little bit, if it's okay, Marisa, about ACT and ERP when you're using them together. And I want us to talk a little bit about what that looks like in a healthy way and in a way that is effective for an effective ERP and ACT integration approach versus when we might be using ACT inappropriately. And I can give an example about that later. But will you start with just a little bit about how you would describe that, how you would explain that should look?
Yeah, and again, it can look many different ways. The way I see it is acceptance is like a big umbrella, and ERP is one way of practicing acceptance, right? And so, like Chris said earlier, like ACT is so much more than a treatment for OCD. It's really a way of being. It's a way of life, and ACT teaches people how to be with all sorts of discomfort and unwanted experiences, and so. When I'm thinking about integrating ACT and ERP, both ACT and ERP are exposure-based therapies, right? So they go quite well together. Hence why I wrote the book, was because often when ACT was first kind of out there, people would look at the difference, like wanting to separate them. And in actuality, I think they go well together. In that, like, you know, I loved being trained in ERP, and I feel like it was extremely helpful. And however, at the end of treatment, sometimes I would notice, like, although clients' Y-box scores went into the with the normal range, like they weren't reporting significant OCD symptoms, they were still dissatisfied in other areas of their life. And the thing I like about ACT is that it adds in this component of living, right? ACT teaches people what to do when they're not engaged in compulsions. So, my language has changed a little bit from being maybe a traditional ERP therapist to integrating ACT a bit more, right? I'm not as focused on the reduction of anxiety, although that is a part of treatment in ACT. The focus is on living. And I think that's a really, really important shift in how we approach it, right? Rather than focusing on habituation, we're focusing on actually experiencing difficult things, uncertainty, obsessions, urges, right? And then noticing what learning comes from that, noticing what you learn about yourself, your ability to embrace uncertainty and discomfort, noticing what you learn about the mind. A part of ACT is called cognitive diffusion, learning how to step back from the mind and recognizing that it's not necessarily the truth, even though it can feel like the truth. It can feel really scary and believable, right? We all buy into the mind, but that once we notice the mind is trying to sell us something, we have a choice in terms of how we show up and whether or not we want to continue to spiral into the mind or choose a different path. And so a big part of what I help folks do is kind of connect them to their values in the beginning of treatment. We focus on acceptance rather than control of trying to get rid of or change. We focus on, rather than feeling happy, we focus on living a happy life and talk about what the differences between those are. And just practice welcoming our sensations in, labeling emotions with the research, with what not just ACT, but inhibitory learning talks about is so important in the process of doing ERP and how it changes the brain just by simply opening up to emotions, right? And I think what ACT teaches folks is that emotions have such a bad rap, especially big, difficult emotions have such a bad rap. But one of the interesting things is, like, if you're willing to really connect to the emotions in your body, right? Every emotion is linked to a physical sensation in the body. If you're willing to connect to that emotion and get a little curious about it, like, what is this sadness or what is this anxiety trying to tell me or trying to remind me of, that's actually quite important to me. Right? It sort of shifts our framework to, like, understanding emotions in this different way, in this, like, hard yet beautiful way of reminding us of those values and what's important to us, because we're not anxious about things we genuinely don't care about.
Can I ask, sorry, Chris, I know.
No, it's all good.
But Marisa, can you explain? So I guess what I'm still curious about is I would love to hear how that's different from ERP. So like maybe like how were you trained in ERP that looks different or vice versa?
Yeah, and I want to, what I want to say is there are really, really good ERP therapists out there that automatically did some of this stuff.
Yeah,
like,
so that's what I'm curious.
Yeah, like I think of like Dr. Joan Davidson, who's such a wonderful ERP therapist, not an ACT therapist, but she does values-based work. The thing about ACT is like, I didn't know to incorporate values until I learned ACT. I didn't know to incorporate diffusion until I learned ACT, right? And so in a traditional ERP model, I was trained back in the day by Edna Foa, Dr. Ziadin, right? It was a very kind of structured model where, you know, we worked on your traditional hierarchy and focused on the reduction of anxiety as we move through the hierarchy. Whereas in a more ACT-based framework, I'm spending more time getting clients willingness to really experience the discomfort, right? I love how Jonathan Grayson says, if a client doesn't understand why they need to be accepting uncertainty, then they're really not ready for exposures. And I feel the same way. And so that's why I will spend more time upfront exploring values, getting good at understanding what the cost of compulsions are, what about engaging in the exposures is important to this person in terms of their values. We practice some cognitive diffusion before engaging in exposures. And we're also helping people label and connect to their emotions and practice mindfulness, being aware of what's happening. And so I'm much more aware of whether or not clients are connected during exposures. Now, I have a lot of clients that come to me, they're like, I did a ERP and it didn't work. I don't think that's the case. I think ERP works. I just think it's the way in which it was done, right? They either push
the way in which you committed, right? I always tell people that like I would be that person that says ERP didn't work for me for 10 years of my life.
Yes.
But it marginally worked, but I was also super stuck. But it was because I wasn't fully engaging in ERP. I was holding on. And so like the model of ERP doesn't work if we aren't, again, back to Grayson's, like Grayson has always talked so much about this. Sometimes he'll say, I spend 3 to 6 months in readiness because again, sometimes I was pushed into ERP, but I wasn't really ready or willing. And so of course I'm going to stay stuck.
Exactly.
Yeah. So I love that. And I want to just have everyone, make sure everyone hears us say that is that what we're saying is that ACT and ERP, it can be a beautifully integrated approach. And many ERP, I consider myself an ERP clinician, not necessarily an ACT clinician, but I absolutely integrate ACT and ERP into all of the ERP I do. It is values-based. It is not rigid. I haven't done a hierarchy in years. Like, you know, all these things that look very different. But again, it's about being able to understand what does that whole client need versus like, let's just have this structured approach, right? It's the whole picture. Chris, sorry.
No, I was gonna jump to a question because this is somebody asked a question that I think a lot of people ask. But to answer your question, Liz, I agree. I mean, I think Marisa is similar to you. Some of the people that trained you trained the people that trained me, and I think for me, especially because we're at a higher level of care, the mindset was always like, people are struggling. We have a wait list. Like, have people come in. Let's focus on getting them better, and then move on. And then one thing that Liz and Michelle Massey did this talk this summer about like treating the whole client. I think that's one thing that ACT really kind of sort of shaped me as a clinician differently, you know, in years is like, okay, great. Like the Y-Box score is down, but this person used to be working, they used to be dating, they used to live on their own, and now they're at home, they're not working, they haven't seen friends in 3 years, and great, their OCD's down, but now we're kind of like throwing them to the wolves. And so I think what's great now is a conversation I've heard a lot more is like, I've noticed that when people have gone to higher levels of care, there's like, this more in the field of like, let's get you a step down therapist who does ERP and ACT and treatment, right? Let's get you back into work. Let's get you to a point now where your life looks the way that you want it to look, and then end treatment, because now the person is so engaged in life, it's harder for them to relapse. I think the reason that sometimes in the older ERP studies, if there was higher levels of kind of like relapse or whatever, it was because people like finished the Y box and then was like, go, versus like, hey, let's figure out what else you could start doing in life. One of the questions I want to throw out, because I hear this all the time, it's from Jansen at 1211 Your Time. Brennan, how do you do values-based ERP when you are unsure of your values since your time is spent worrying? So I think that's something I hear a lot when I introduce ACT to clients, when I see people post about it, is my life has been so dominated from OCD for 8 years, 7 years. I don't even know my values. What are some good techniques for therapists or clients to figure out what their values are so they can start engaging in them over OCD?
Yeah, so I with most of the clients that I work with, I start with a values card sort. And so you could probably just Google ACT values card sort nowadays, or you're welcome to email me or check it out in my book. Dr. Robin Walzer came up with a values card sort, and she allowed me to use it, and so and to give it to folks. And so it's just a wonderful exercise that gets people really, really clear on what are values. Because I think most people assume that they're actually life domains. Like, for example, like I want to, I want to focus on being a mom, or I want to focus on being like a career person. Like, well, what kind of a mom do you want to be? What type of career person do you want to be? So I get really specific on not only identifying the values, but defining them, because for each of us, they can mean something a little bit different. And so values card sort, I think, is a beautiful way to start. I also recommend a good like intro to ACT book is Russ Harris's The Happiness Trap. It's not necessarily OCD specific, but it does talk about acceptance in a very like concrete way. And there are some values exercises in that book as well.
Another thing I really like, it's Little Light Soldier at 1214 Brennan. I'm trying to figure out when it's not OCD. Do you find that helping clients with ACT helps them identify more of like what is OCD and what is not? And the reason I ask this question is because while doing values-based work and somebody starting to know themselves again, in my opinion and my clinical experience, people start to know what OCD is or isn't because they're starting to know who they are, what kind of person they are, what kind of person they want to be. They start to really kind of trust the insides of like a human. So then when OCD is like, hey, you want to kill your kids, it's like easier to be like, no, I don't. Versus when they weren't doing any treatment, OCD could say what they want and they sort of lost their identity. And so they sort of go with it. So how can ACT help people figure out what OCD is and what OCD isn't?
Yeah, I mean, I think when most folks come to treatment, the OCD is already loud and saying things pretty clearly. And their values are quieter, right? Like they're in there, but they're not as loud. And so by doing values-based exercises, it gives a voice to their values. They get really clear on like, oh, this is what matters to me, right? And then through the course of doing exposures, through the course of doing the values-based exercises, they do gain clarity in terms of like, oh, this is fear versus this is what's in my heart. These are my values.
Absolutely.
And Liz kind of mentioned earlier, sometimes, especially with perfectionism, right? Values, OCD or perfectionism can hijack values sometimes, and that can get a little tricky. These are folks that maybe choose success as a value, or and perfectionism, I think, is a very important thing to also address in therapy, because it can hijack a lot of the therapy, not just values. But one of the cool things about doing these value exercises and really working on the perfectionism and the OCD is that through the course of treatment, folks start to recognize that, ooh, I think perfectionism may have chosen this value, or I think perfectionism may have defined this value. And we'll talk about like, well, what would you define it as now that you've recognized that? And they go from saying things like, oh, success meant making a certain amount of money or getting a certain promotion, to success actually means having more balance in my life. And it's really cool to like watch that shift.
Yeah, that's kind of what Liz was saying, is like how, what if people are using their values as a reason to compulse? And I think you addressed it well. Another question that I like from, if you could put it up, Brennan, at 1214 from Samay, as we know, OCD is based on compulsive behavior. Is it possible to shift that compulsivity on enhancing studying? So one of the things, going back to like values work and stuff, sometimes people will say, oh, because of my OCD, if I just shift it to my studying, I can study well. Or, it's a value to be clean. So maybe I won't clean all night, but maybe I can be more clean. Like, once again, kind of what Liz was saying, how do you sort of separate, like, this is a value, this is a way of being, this is a way of my life that enhances it, versus like, oh, I'm going to give credit to OCD as enhancing certain like values or behaviors, because people, especially around school and perfectionism, like you're saying, I see people like use that as like, oh, but it's helping my values because I'm doing better by studying and not going out with friends, and I value studying more than my friendships or something like that.
Right. And if the behavior is actually in line with your values, we don't want to get rid of it, right? Like, if studying is something that's really important to you, we don't necessarily want to not study. We want to study, and we want to do it in a good enough way. Right. And so it's a matter of like kind of really thinking about like, how much time and energy am I willing to put into this? We don't want to put in too much, and we don't want to put in too little. So what would good enough look like? And sometimes folks are, able to come up with, it looks like this and that. Other times we survey other people, like, how much time do most of your peers put in terms of studying, right? And take a look at what it's like to kind of to match that. We don't want to get rid of anxiety. Right? It's a helpful thing to have. I mean, think about all the cool things that we have going on in our life or have achieved in our life. Anxiety helped us get there, right? We just want to lower the volume a bit and cut back on some of those unhelpful behaviors.
So let's get into the nitty gritty here of an example. Let's do it around perfectionism, because I think that's a perfect example. Is that so? I had somebody come to me recently and say, ERP is not working for me, but I'm also like not really willing to do it. And I was like, okay, walk me through it. And they were talking about perfectionism, ERP for them, and that their clinician wanted them to purposely make mistakes. And they were like, I'm not willing to do ERP. And so the family was coming saying, hey, ERP won't work for our loved one because they're not willing to do it. And I had to spend some time saying, well, wait a second, let's actually talk about what values-based ERP should look like, right? Making a mistake and purposely turning in something, they're in college, but turning in an assignment with a mistake isn't something we actually have to do as a part of ERP. Excuse me. They're like, well, what are you talking about? Like, an exposure is to make a mistake, and the response prevention is like, turn it in. And I was like, yeah, but is that your value? Well, no, I don't want to make mistakes. And it was like, okay, so then let's talk about what ERP could look like that's actually values-based. And so, Marisa, could you walk us through that? Sorry if I'm freezing. I'm freezing on my end. But it'd be great if you could walk through actually how do we do ERP from an ACT lens and use ERP and ACT for that same fear, right? The fear of making a mistake. We know that it's taking them hours to do their homework. They don't want to do ERP because they think that means making a mistake. What would ERP with them for you look like instead?
Yeah, I think one part of acceptance, right, is and this kind of relates to perfectionism. Perfectionism is very outcome focused, right? Like, perfectionism is focused on the specific outcome. I don't want to make a mistake. And the thing about values-based living is that it's focused on the process. So it totally makes sense that perhaps you don't want to make a mistake. Most people don't want to make mistakes. And yet, how is this impacting how you show up in your day-to-day life? Right? What about engaging in the compulsions, right, is costly? And so what would a good enough look like? If you're not willing to make a mistake, which you don't have to do because it's not in line with your values, right? What do you want to let go of? What is in line with your values? How does this get in the way of your values? Right? Because I'll have some folks that I work with that are so scared of making a mistake, they won't hand anything in at all.
Mm-hmm.
And then it
like late or yeah.
Exactly. Right. And so what are you, if you're not willing to do that, what are you willing to do? And I would probably work on a little bit of acceptance and compassion around the fact that, like, you will make a mistake. We all do. It's a normal part of being a human being. And the only thing we have control over is how do we treat ourselves when we do make a mistake?
I like this question from Eric Davis. I want to throw out it, if you could put it up on the screen, Brendan, at 1225. It says, as an OCD sufferer for many years, I still struggle to get through exposures without ruminating. How can I use ACT and cognitive diffusion more effectively?
Yeah. So, Eric, the first thing I want to say is like, you will ruminate at times. Like, we don't have control over the mind initially, right? Like, you will ruminate. The beautiful thing is that you're catching yourself ruminating. And so, once you notice yourself ruminating, then you have a choice around like, okay, what do I want to do? Do I want to continue to spiral into rumination, or do I want to try something different? And so sometimes having specific prompts to focus on while doing the exposure can be helpful. And when I say prompts, there's a difference between this and distraction, in that these prompts actually help you get more connected to the emotion and the fear, rather than take you away from it. And so it's one of the reasons why I like using scripts in exposures, because I find that it actually helps people connect to their fear and feelings and be more present with the experience, right? And so if you catch yourself ruminating while doing an exposure, what I would encourage you to do is take yourself back to the fear. What am I most fearful of right now? Right? And can I give it a little IDK? I don't know if that'll happen, or we'll see, right? Notice what it feels like in the body, and then ask yourself, how do I want to show up in this moment? And bring your attention to that. Using our senses is also very helpful in bringing us into the here and now. What do I see? What do I smell? What do I taste? What do I hear? What do I feel?
I think additionally, like I was just gonna say, like the cognitive diffusion part. What I liked about like about it in ACT is like you're really treating the OCD as like an other. You're not thinking of it as like, this is me. And I think that's where people get stuck with perfectionism, or people get stuck with ruminating. But when you start to, like, one of the first things I do with clients is like, let's talk about OCD. Like, if it was a person in your life, how would they be? Would they be shouting at you all the time and yelling and scary? Would they be like a scared little frightened child? Would they be like the mean girl and bossy? How would OCD sound? How would she dress? What does she look like? Right? Like, kind of describing it almost as a person. And what clients always come back is like, it helps with that diffusion. It helps me be an observer of my thought versus my thought feeling like me. So if I'm going to, touch the crosswalk button to go across the street, previously before treatment, it would feel like this would definitely make me sick. Now it feels like somebody who's kind of been bullying me and bossing me around for the last 5 years since my OCD has been bad is sort of bullying me into being like, don't press that button. And it's easier for the client to say, look, I am choosing to press that button because I'm tired of standing here and waiting until somebody else comes, or like sprinting across the street so I don't get hit. Like, I'm choosing to press the button. It is important for me to be able to get to where I want to go. And I hear the thought, but I'm choosing not to sit there and treat the thought as if it's a fact or a need to do. And so that cognitive diffusion of making the thought an observable thing, give it a voice, a look, a name, right? Versus having it be you. Because if people think that their OCD is them, they're not going to be willing. Going back to Liz's example, if they think that the OCD is them and doing great in school and their values is wrapped up in perfectionism, they're not going to do the treatment. But if they can recognize that the disorder is an other, trying to bully them in to be perfect, which is really leading to them to be stressed, come to treatment, not turn things in, it's easier to respond to that versus responding to yourself.
Yes. One of my favorite exercises is imagine OCD sitting on one shoulder and your values sitting on the other, right? What would each of them guide you to do in this moment? And ultimately, what do you choose?
Yeah. So the one thing I want to really hone in on too for a second could be this. So it could be totally wrong. So Eric, ignore me if I'm wrong. But I find sometimes that we or our patients both, I guess, me too, not using ACT with ERP effectively. And so at times, some of these strategies can actually keep us a bit stuck. So I want to talk for a little bit about how we need to become really thoughtful about any strategy we're using, ACT, DBT, ERP, it doesn't matter what the function of it is. So I want to give a couple examples. So I find that if we are still really entrenched in our thoughts and we're still ruminating and we're still getting pulled into it, we're stuck, I want to be very clear that none of us are suggesting that we take strategies to try to distract ourselves, right? Because when we're using the strategies as a distraction technique, we are going to stay stuck in the rumination, and it's going to keep popping up, and we're going to feel like this isn't working. And then we might think, well, how do I use cognitive diffusion, or how do I use something to get rid of this thought? But it's really because we're not actually approaching the thought. So I want to be really clear that part of the model that actually works is approaching the thought, but through using ACT and others as this lens in a way in which we approach it and the way that we respond later. So I'll give an example, but I recently was working with someone who they were saying, Liz, I'm doing the exposure, I'm facing my fears. So the exposure was like being in a certain place. They're like, I'm in that place, but I'm still super triggered by it. It's still coming up. I'm still really worried about it. And I was like, well, tell me what's going on. And they then gave the example that like, okay, I'm in that place, but every time I get triggered about being in that place and I'm worried that like I'm doing something wrong and something's going to happen, I'm using an ACT technique of like noticing a picture on the wall, and I'm noticing the color of it. I'm describing the color of it. I'm purposely thinking of the color of it. And then I'm bringing my attention back to the place, but I'm still worried about it. My response is like, well, we're using the strategy wrong, right? Like we're using the strategy to distract ourselves. So of course we stay stuck with the fear. And that's actually not the right time to use the strategy. So Marisa, can you talk a little bit about that and just how we need to be so thoughtful about when and where, and not picking and choosing strategies that actually we're using them for our anxiety versus for treatment?
Yes, because anything can be used as avoidance, even ERP, right? Like even ERP, like anything can be used as avoidance. And so it's all about the function of the behavior, right? Like what's driving that behavior? Are you doing it to move closer to your experiences? Or are you doing it to pull you away from your experiences, right? And the whole part of exposure-based therapies, ERP and ACT, is really about moving towards our experiences. So that way, when obsessions, urges, feelings, thoughts, when they show up, you're out there living your life and these experiences show up, you don't get so thrown off your game. You're like, oh yeah, there's that experience. I don't want it, but I'm willing to have it. And I'm choosing to refocus on something else, right? And so, I can tell my clients till they're blue in their face that they're capable of having their experiences, right? But they don't know they're capable of having their experiences until they're willing to actually practice having them. And in the short term, that is going to bring up more distress and more discomfort, but it's always in the service of getting good at having those experiences. So that way, when they are out there living their lives, they're able to be more present and engaged in the things that are important to them. And that's kind of how I define exposures in an ACT lens, if you will. The whole point of doing acceptance-based ERP is to really get good at having the experiences. So when they show up and the person's living their life, they're like, I got this. I know what to do. I got this, and I can go about my life.
So could you walk through specifically what that would look like? So a patient, is at the restaurant, they're triggered by this restaurant because they feel like it's contaminated from a previous experience. They keep having these thoughts about, oh, it must be contaminated, or I'm getting contaminated. Let me look at this picture. They're noticing the red on the picture. They're noticing the colors in it. And they're like, okay, I feel a little bit better. I'm going to bring myself back. Oh, but it's still there. I'm still triggered by the restaurant being contaminated. What should they do instead? What would it
be? So I like to start off a script with a little bit of diffusion, right? So I'm noticing the mind saying that this is contaminated, and I might get sick. I might, whatever it is. And I don't know, I like using Alec Pollard's core fear model. I don't know if I can handle this feeling of anxiety, or I don't know if I can handle not knowing if I'm contaminated, right? I feel blank. Label your emotion. How are you feeling in that moment? And drop into the body. Notice what those sensations feel like, right? And then a little bit of a dialogue back to the OCD, nothing too big, but more like, I don't know what's going to happen. Right? Let's see. We'll see. I'm willing to take the risk of possibly being contaminated in the service of what?
I always tell people that, like, it's not about saying, oh, I am contaminated. This is terrible, right? And like leaning into that. And you don't even have to say like, oh, I'm probably getting contaminated. I'm probably going to, but it's about being able to be like, oh, like, I'm worried that I might be getting contaminated right now, but I'm going to choose to have this meal with my mom because that's what I want to be doing today. And I'm not going to figure that out. So it's about allowing space for that fear and that core fear to come up, but choosing not to answer it. Right. And then ACT comes in the sense that, like, yeah, I'm recognizing, I'm acknowledging, I'm allowing space, but I'm moving through it. And the ERP comes in because you're in the restaurant, you're not doing rituals, you're not ruminating.
And I think a part of acceptance is accepting the fact that we don't know.
And we can't figure it out anyways. And that's what I always tell people. I'm like, well, what's the alternative? We get stuck trying to figure this out for hours and we actually can't get an answer on anything OCD wants us to have an answer of. That's why it sticks, right? It's stuck to begin with because we do not know. And so I want to go back to this for just a second. Bring it on mentality that Amy's saying. This is my like new language I've been using this week. I always have new language every week, and Chris is probably so annoyed. But it's this like, are we sitting there with this mentality of like, bring it on? Like, okay, OCD, bring it on, and I'm going to move through it. Or is this like, I'm afraid of it, it can't be there, I need to distract myself or do any sort of behavior to not have to be worried, right? So again, it's that, when we say allow space, we mean just like not being afraid, right? Not responding as if you need to be fearful or figure out what OCD is throwing at you.
What I want to say is it's okay to be afraid, but you can be afraid and courageous at the same time.
Yeah. You're right. I don't want to invalidate or dismiss the feelings of fear, but it doesn't mean we have to respond to the fear.
And you're bringing up a beautiful point, Liz. Language is powerful. Language is so powerful, right? So I say, like, when you're doing an exposure, like, use whatever words help you connect with your fear and feelings. Like, I always encourage my clients to come up with their own kind of responses. And for some people, it looks like bring it on OCD, right? And for other people, it looks a little bit different, but it's about using the words and language that really help you connect to the fear and feelings.
Marisa, I want to throw this question up because I think DJ IBG's question on YouTube at 1229 Brennan is really good. It says, my biggest challenge is that my values feel super insignificant, even ridiculous compared to my fears. Any tips to help that? So we've been talking a lot about values. What if the person, I think we all do this with OCD, we absolutely prioritize our fears and we feel like our values can take a back seat, or like, I'll get to it in a year, or like, I have these 8 things I'm worried about and then I can do a value thing. So how does somebody incorporate values if they feel insignificant?
Right. So, I mean, a part of this is like, noticing who's saying that your values are insignificant. Like, notice where that is coming from. Right. And so we all have this internal critic, right? That's a part of the mind. And what I want to say is we're all deserving of love and kindness. And so noticing whether or not that thought of like your values are insignificant, is that thought helpful? When you focus on that thought, does it help motivate you to live your values? Or is it demotivating? Right? And if you find that thought to be actually unhelpful, then that's a beautiful opportunity to practice diffusion. Right? By doing something like, noticing what the OCD looks like, sounds like, and it's saying it to you. Notice what it looks like on the big movie screen or a billboard as you're driving down the street, right? But noticing that thought is a part of the OCD, that thought is a part of the mind. And if you find that thought to be unhelpful in terms of being present in your life and moving you closer to the things that are important to you, it's a beautiful opportunity to practice that diffusion.
I think too, to answer that question, I mean, it's so important for people to learn what's going on. One of the things I do with every client in the beginning is I say, look, we will definitely address your specific subtype. I know that there's certain ways of thinking because of that subtype, but let's kind of look under the hood and see the mechanics of OCD. And one of the mechanics of OCD is we know that a lot of the way that the brain works, we have this limbic system. It's all where all of our emotions are stored. We have our amygdala, which sends signals to our orbital frontal cortex that there's danger. It's hyperactive, right? And so your brain is all about survival. It's always going to prioritize risk and prioritize fear and prioritize danger. The problem is it's literally like on super, somebody turned, like you were saying earlier, Marisa, like the volume is turned so high. And so I think part of also treatment is teaching yourself, well, the therapist teaching the client that every day wake up. I think part of the acceptance component I tell clients is like, if somebody has a broken foot, they don't wake up the next day and be like, oh my God, I'm shocked, my foot's still broken, right? They know it's going to be broken. But with OCD, we wake up and we're like, rats, why am I having a thought today? It's like, factor it in. You're going to wake up, you're going to have thoughts around your theme. If your theme is around, blurting out racist statements, like, the second you leave your house and you walk by somebody, you're going to have that thought come up. Like, let's already kind of factor that in. Let's expect that. And then it's your job to say, look, I can absolutely react to that fear part of my brain. And then sure, all your fears are going to always overpower your values. Or you could simply say, look, this is day 3,804 of me getting the same boring thought and me doing the same boring compulsions. What if I just tried engaging in something I care about today? So I think that's important, is like, people got to learn what's going on, because if you don't know what's going on in the brain, of course, every time you have a fear, you're going to jump and react to it.
Right. And as you live your life, right, do you think it's going to be possible for fear and doubt to not show up?
I wish, right?
I do too.
But you can't.
It's going to show up, right? And so look at it as like, so when it does, what do I want to do?
That's right. And what we see, and I want to just point out, is it's going to show up in everyone's life. We're not saying just your life, right? I've got a 1 and a 2-year-old, and it's amazing because you get to like see this in action every day with like these moments of like, I'm scared, and can I still do it? And as the mom, you're like encouraging that, like, yeah, this is hard and you can do it, right? Like, both things can be true. I don't have to say, oh, Olivia, that's not hard. Oh, Olivia, that's right. No, it's like, yes, this feels hard and scary, and I know you can do it, right? And that's what we're trying to teach you. And the reality is that the more you are doing ERP with the ACT lens, right? Or the more you're doing ERP with a values-based lens, you're going to build your own confidence too. Right? Like, you're scared right now. It makes sense. If Chris told me I needed to go run a marathon, I'd be like, that's not going to happen. Like, I can't do that right now. But if we had a training plan and we practiced and he gave me enough time, like, I would maybe be able to do that in a year or so. If someone really needed me to, I'd prefer to just send Callie, but I could try. But like, you think about it as like, part of this is that we're going to start doing it, and we're going to do it slowly. We're not going to start with your hardest fears. Like, we do still do a systematic approach, because we want to build your confidence in doing it right, so that you actually can see the results. And as it starts to click, you start to see how you can generalize this work for life. And I think what Marisa's saying, I love, is that like, this isn't just about OCD. This is about life. And this is about how, and that I think is where this ACT lens and ACT perspective and ACT intervention / approach really makes such a big difference, is that I do think it allows you to not look at treatment as ERP for OCD, but it's actually like treatment for life. Yeah. Yes, we integrate it with ERP for OCD, but then we also have so many skills now that can generalize not just to our life, but we see it in other people, right? I always tell people, like, when I know you're at the best place in treatment is when you come to me and you're like, our patients will come to us and they'll say things like, well, Liz, like, I noticed what my mom was doing the other day. She was feeding all of her anxiety. And if she would just do this instead, it was like, these are the moments where you're seeing that this work can apply to life, right? To the real world, not just to your current fears and triggers.
And the interesting thing about values, including acceptance, is that it's lifelong, right? Like, we'll never be 100% accepting. We'll never be 100% loving, right? Like, we can always be more loving. We can always be more accepting. And this is a process that we're all in, right? Because suffering is a part of life. And for some people, suffering is OCD. And for other people, there's other types of suffering. But kind of reminding yourself, like, one, you're not alone in it, which is one of the reasons why I love support groups. And two, like, this is a lifelong process of acceptance, of learning how to be with experiences, and living a purposeful life is something that folks with OCD can do. They are capable of doing. And again, a part of facing discomfort is learning that you can do it. OCD is great at telling people you can't. And the only way to really learn that you can is by doing the hard thing. The harder the challenge, the greater the learning. I borrow that from Lisa Coyne, right?
I think too, one of the things that people hear sometimes on these live streams, what you just said is like, they hear that, right? And they're so desperate to find a treatment modality that can promise you that you won't have to have any hard experiences in treatment, right? Like people are always looking for that. I used to run gyms before I became a therapist, and there were so many people that did not want the gym membership. They finally caved in because they're like, I spent 7 years trying to figure out a way to get into a good state of health without having to do the hard work, right? And I finally just realized it comes back down to the gym, right? I think the same thing comes for OCD treatment. There's so many people trying to market treatment, like you can do treatment, but don't have to struggle. But I think one of the things I love about this conversation, I love about ACT, we have Susan Boaz, the president of the board, who is talking about this at the board meeting. It's like, what I always tell my clients is the stuff you're doing in treatment is going to be a life lesson that will always help you. You can choose to live a life that's never difficult. And unfortunately, it's probably going to be very local and small. Or you can say, you know what, anything I want, right? If I want to, get married, if I want to start a nonprofit, if I want to do charitable work, it's going to be challenging. It's going to create change. It's going to create me to kind of dig deep in stuff. And what I like about ACT and what I feel like ACT has done really well is like, let's not look at that as a bad thing anymore. Let's look at that growth. Let's look at that spontaneity and that like not always knowing what's around the corner as like an awesome part of human existence. Let's step up to the challenge. And I think when people are talking about like learning to trust yourself, I think that's what happens in ERP and ACT. You say, look, like I just did that. I have a client who hadn't celebrated her birthday in 6 years, and she started the treatment and she's like, well, my birthday's this Sunday. It's too soon to start a treatment. Like, we'll get them next year. And I was like, no, we're going to celebrate your birthday. We will figure out how to do it. And it was like the Monday when she came back from the birthday celebration, she was like, I did that. Like, that's how people grow in confidence and self-esteem. And so, that's what I love about the verbiage that you're using. I'm on a board with Evie Gould, who talks about this. You've done a book with, Lisa Coyne. Is like, that is not a bad thing. Learning to step up into your values and to challenge hard, difficult things in treatment should not looked at as a bad thing. It should be looked as an amazing opportunity for growth.
Beautifully put.
Sorry, I just am so inspired by this talk.
Yes. No, I love it so much. And it's so interesting, Marisa, because I feel like we talk so much about like values-based ERP, but really it is so important to talk about this from an ACT perspective and how ACT is kind of values-based ERP, right? Like ACT and ERP means like that's the model in the therapeutic lens in which clinicians, if you're really using like ACT and ERP, you should feel confident, I hope, that it should be values-based.
Yeah, I mean, that's a big part of ACT. And when I initially started learning ACT, I would basically do ACT plus values. And then throughout the years and throughout the training, I would incorporate more and more of ACT, such as diffusion, self as context, present moment, committed action, right? There are other processes that are included in ACT, and getting to those values is a beautiful way to start the process. It's not easy to learn ACT. It's hard. And it's an experiential based process, which means like you need to experience it in order to learn it. And so you need to, as a therapist, you need to be willing to actually engage in ACT, I feel, in order to really learn it and in order to be able to actually do it with your clients.
Totally. Well, this has been amazing and inspiring, and I feel like we need a part 2. If you're willing, Marisa, I would love to get into the throes of ACT language. So like definitions, concepts, what that looks like, how you use it for ERP, because I feel like this was an amazing overview, but would love to go into the weeds even more. So thank you so much for your time. Thank you all for joining. I hope everyone had a wonderful Thanksgiving, and we're heading into December. Lots of live streams planned. I believe next week we are going to have, is Sanj joining us, Chris? Next week? Yes. So Dr. Saxena will be with us next week as we are going to dive into the throes of medication for OCD. So next week we'll have main focus for our live stream is going to be on medication, but of course our community live streams continue to happen Tuesday evening. And as always, feel free to go to iocdf.org/peace of mind to learn more about upcoming streams, upcoming programming, and to submit content that you want. Thank you, Marisa, for your time. It has been incredible. Excited to work with you in the future.
Yes. See you soon.
Yes. Thank you, Marisa. And bring your medication questions next Wednesday, same time. We'll have a psychiatrist on. Marisa, thank you for being our guest, and we'll have you back for part 2.
Wonderful. Thank you.